Welcome to our new COVID-19 interview series called Rising to Meet the Moment, where we engage with stakeholders to discuss how different aspects of the behavioral health system are responding to COVID-19 and rising to meet the moment. I'm Kevin Riggs on behalf of the Behavioral Health Action Coalition, whose mission is to engage California leaders to prioritize behavioral health issues and to reduce stigma. With me today is Cherie Lowe, Vice President for the California Hospital Association and one of BHA's co-founders, and joining Cherie and me is Steve Fields, the Executive Director of Progress Foundation, a nonprofit that operates 19 programs across San Francisco, Sonoma, and Napa counties, serving more than 3,000 people a year. Steve, thanks for taking the time.
You're welcome. Thank you.
Let's start, Steve, with your background. Obviously, Progress Foundation has a sizable footprint, but give me some sense for what the foundation does and also your role with the California Association of Social Rehabilitation Agencies.
Yeah, commonly called CASRA, so we don't have to waste time with saying it. Progress Foundation is celebrated its 50th anniversary just this past year. We're going to have a big celebration in May, and this thing called coronavirus pandemic interfered in that, like a lot of people's lives. We were founded really in the dawn of deinstitutionalization in California, the policy of moving people out of state hospitals who were severely mentally ill into what was designed, hoped to be a vital community mental health system. And so we started with a goal of specifically trying to provide community-based services, 24-hour residential treatment services that were an analog and an alternative, therefore, to institutional beds. So our mission since we started has been to try and develop programs in the community that could serve many clients who are assumed to need inpatient treatment involuntarily, skilled nursing placement out of county, state hospitals still, because that was still a vital part of our system through the 70s and into the 80s as a mental health system. So that's what we've been doing. So our mission has been to look for a person who's at risk of being institutionalized or is being institutionalized and try to develop a program that could have prevented that from happening, both in the moment of the decision, but also presenting a continuum of care that underscores programs that help people live in the community, be vital parts of the community indefinitely without having to cycle through hospitalization because an exacerbation of their mental illness. So we have a continuum of care that has that goal.
You certainly don't lack for the number of people who need the help. How has the group grown since it was founded?
Well, we started as a little halfway house in 1969 for 6 clients. That's when I started working for Progress Foundation. And now we have these 19 programs across counties. We've articulated a continuum from acute diversion from inpatient and from emergency room to transitional residential treatment, 90-day and 6-month programs and 1-year programs in the community that offer treatment. And then a series of apartments, supported living apartments, scattered sites throughout the community. So the goal had always been to try to prevent the hospitalization if possible, provide treatment in the community that is long enough to actually help someone get their feet back under them and make a commitment to sobriety or being sober, and then support them as long as they may need it in the community, but in the least restrictive kind of environment. So we've gotten more sophisticated in our treatment technologies. We've got more sophisticated in our system design for various counties, but it's the growth that's been the most dramatic.
Do you think you could be a model in terms of other organizations who might want to offer these services?
Well, yeah, I do believe we could be. And I think that's actually one of the problems is that the growth of models, the adoption of new models, this language we always use about best practices, in California in particular, has some serious barriers for replication of effective models. And so you see, I give an example. We're across the bay from Alameda County, and Alameda County got their first true crisis residential programs just 2 years ago, whereas we opened our first one in 1978. So you would think there would be some cross-pollination of ideas and adaptation of programs in that close an environment with very similar urban settings. No, totally different mental health systems for decades before things started to change. So I would like to see us be able to be an adaptable model that fits the needs of a particular community. But alternatives to institutional and hospitalization treatment are not prevalent around the state of California today. And I think there are a lot of reasons for that.
Cherie, I'm going to pass it over to you.
Thanks, Kevin. And Steve, thanks so much for joining us. I am a big fan of your model, and anything that we can do to get it replicated around the state for the people that we're trying to serve, I think would be time and energy well spent. Let's turn to the coronavirus pandemic if we can. And I really have two questions for you. The first question is, what do you think the impact of the pandemic has really had on our entire delivery system? And then the second question will be, there's got to be some opportunities that this pandemic presents for us. So first the impact and then the opportunities.
Well, I guess, there's the first and foremost, the most practical one that everybody has to be concerned about is that the impact financially on the capacity of our community, county-based systems of care to maintain what they have, even if they had goals of changing it and improving it, has really been stopped in its tracks with the kind of deficits the various counties are facing for their systems. So we're looking at reductions of systems of care starting in July. We haven't seen the county-based reaction to the revenue loss really yet until we see the next fiscal year starting. And of course, it's dependent on federal and state help, but right now, we don't know when that would be forthcoming. So that is the first thing. The resources to provide services ends up being the first threatened and now seriously diminished capacity. And I think on the other way is it's caused systems to do one of two things, and to lead into the second question. The first is lock some systems into not doing any change, kind of holding on to the system they have and seeing it scale down, and therefore with loss of resources becomes a kind of static service system that might have been moving toward change, but was locked into a response of just holding on to what we have. The second possibility that I see happening perhaps in some, and we'll see it in the coming year, is this is a long-term necessity to look at how we use our resources differently, how we have money being spent in some places where we could actually look at alternatives and other ways to do things. And but it needs a state leadership. It needs some voice, some engagement at the state level, because otherwise we have 58 counties and jurisdictions all responding separately to their particular dilemma. So I think there's a real opportunity in this system right now with the proper leadership. I'm hopeful that the governor's high priority for behavioral health services, the fact that he has some folks around him advising him and talking to him, will lean toward providing the kind of technical assistance, the kind of leadership, the kind of cross-pollination of ideas that will help counties see here's an opportunity to shift your service system perhaps in a direction that will actually be better for clients and consumers long-term, instead of being stuck in the same paradigm of institutional and supported living programs in our community.
Perhaps we'll see some replication of your model.
Perhaps, yeah. We're always open for visits.
Well, obviously, we're still a long way from working our way through this pandemic as we see different spikes starting to form. Let me just be simplistic, though. If you could wave a magic wand, Steve, and just do one thing that would help the system and the individuals and the families who are in that system, what would that one thing be?
Well, I guess, and Cherie knows that this is a pre-COVID wand issue I have that remains, but I think based on the previous comments I made, If we could come to a statewide agreement about what a system of care needs to look like in the community to serve people that draws on other examples, it's not just mine. There are other counties that have done some creative things. If we could use an opportunity as a statewide crisis around COVID to also say we're going to match that with our previous commitment to rethinking and reforming our behavioral health system. And one of those has to be statewide leadership. There has to be a way of articulating to counties around the state that there is a basic model of community-based services that you should all have. How it looks based on whether you're a rural county or whether you're a huge urban county, how many of them there need to be at various levels of care. Those are all things that I think local control determines, but we do not have a template in this state what a community mental health system in 2020 should look like. And we all know basically what those elements are. And we need leadership to say to counties, you get substantial state funding, you get substantial Medicaid funding flowing through Medi-Cal, and you're spending local dollars. We want you to have a plan to come into developing a continuum of care that isn't different in San Diego than it is in Orange, than it is in LA, than it is in San Francisco, than it is in Eureka. We need to have that kind of state leadership. I think it's on the verge, yeah.
In the meantime, as the foundation continues to work with this COVID-19 pandemic, is there an inspirational story or an anecdote that comes to mind that you want to share?
Well, you know, I guess the inspirational story for me is I'm on the phone virtually every day now. You know, we're struggling with 24-hour residential treatment programs that are in the community with 8-10 clients living in a household in a congregate setting with social model treatment intervention, which means we interact with one, we have dinner together. The clients and staff cook meals, they share meals. So it's a treatment program that looks at a social relational approach to treatment. That's what social rehabilitation is in a sense, and that's the kind of programs that CASRA promotes. And what I've been inspired by is, in a weird kind of way, this COVID crisis, which is about a response that says shelter in home. When I've talked with my staff members and on, you know, in Zoom calls and with my leadership, our treatment model is really close to the experience of clients when they're sheltered at home. They're in a human scale environment. They have time to be working on their problems. They're exactly paralleling the problem the general society has. So this idea that the mentally ill should be separated out and be somewhere else rather than in our community. Well, they're now in our communities experiencing the same thing that the tech guy down the street experiencing, staying at home. We have this, and it's a plus for us. It's a strength for us because we deal with people in their homes all day long. So the inspirational part to me has been to hear the creativity of the staff members who are having to adapt in each program, their own program, but they're all built around more interaction with clients, less difference between clients and staff. You see it starting to diminish because they're all frightened of and dealing with the same pressure. It's not about mental illness. It's about being healthy and surviving and living in a community and taking boundaries and so what's been inspirational is you see this model and say, you know, if there was a model in behavioral health made for a stay-at-home order, it's social rehabilitation in the community because we're already practicing that on a mental health treatment intervention level, let alone a pandemic response. So I've
Interesting. Cherie?
Well, to me, it sounds like you've got a common denominator. Unfortunately, it's a little bit of fear, but it's a common denominator between the consumers you're serving and the staff providing the service.
Absolutely.
And you don't often...
Yeah, just the discussion around risk of people coming into the program. We had a meeting in all the houses immediately where we were saying it's not the clients that are the only risk, it's the staff members who go home at night. We don't know where they're going, where their partner is going. The staff have to be as conscious of their role in maintaining safety as the clients are. And immediately it caused them to see their commonality, how
Right.
they're struggling with the same thing. There was no way we could say, oh, those mentally ill people are the risk. We're fine. And that discussion was led by the clients. And I'm talking about clients in acute diversion who came in right out of the emergency room, raising those questions because we have a forum, we have a treatment intervention model that encourages conversation and discussion. And you start to see it erasing the stigmatization that's even in a program that's committed to fighting stigma.
Right, right. Hey, let's transition to Black Lives Matter. And I'm going to read a quote from a recent newsletter that came out from CASRA, the California Association of Social Rehab Agencies. And this is what it says. CASRA and its member organizations join others to acknowledge their tremendous pain, trauma, and the opportunity we face to support fundamental transformation change that recognizes the depth and breadth of institutional racism and how it touches all of us. So, Steve, we know that you're a recognized thought leader in the behavioral health, mental health, and social rehab system, and you've been actively engaged in efforts to transform over the past half a century, trying to create some positive change. So with so much happening in the past 2 or 3 months, COVID and now Black Lives Matters, can you talk to us a little bit about what you see happening in the context surrounding Black Lives Matter?
Yes, I think again from seeing it in these sort of little examples of these residents of people living together and then the staff that have been expressing things. A fundamental element of social rehabilitation is that diagnosis is not the determining factor in whether somebody comes into the mental health system or ever gets out. What's the determining factor with people that we meet is they come from backgrounds and lives, irrespective of what their biochemical susceptibility may be to mental illness. The fact that it turns into arrests or constant use of emergency rooms, and it is about talking to folks about where they come from in their lives. And it's the fact of the matter that one of the challenges the behavioral health system has is that I bet you in every single county, but it's certainly true in San Francisco, with all these programs that we have in the city, the African-American population has been diminishing in the city because of income inequality. And it's about 4 to 5% now. But the number of individuals in the psychiatric emergency rooms and in the hospital who are Black San Franciscans hovers between 25 and 30%. Now that is not a diagnosis-based problem. That's a problem of communities with health inequities, communities of trauma, communities where violence was a part of every young person growing up. That's part of social inequalities, and we've always believed. And in fact, I was one of the coiners of the term social rehabilitation, and I always would explain to people it's not about rehabilitating the clients to be better socially. It was helping them give skills to survive in a social context. But it was also about saying to society, you have some rehabilitation to do. You are institutionalizing tens of thousands of people without looking at an alternative. Now that we're in the community-based system thing, we still have serious things to look at about why are those inequities clear in the psychiatric emergency room? What are we going to do to finally address programs that meet the needs of those individuals? And it's not just Black Californians, it's brown Californians, it's people who come out of poverty. When we intervene, we're intervening on putting together a social support system for our clients before we worry about whether they're going to stop hallucinating. We're talking to them about how do you get the underpinnings that others have had the advantage of to help you not be pulled down each time you get better, each time you have some ambition to go look for a job or get back into the job market. How do we give you the tools and a systemic responsibility for that so that you can start to move back into society on your terms rather than constantly be in this subterranean world of mental illness that we keep stigmatizing and separating. And so, I think this movement and the fact that it's forcing us, who knows how long it lasts, knows how long it's going to retain its energy, is forcing us to look at the way we are too narrow in our definitions of what we consider someone who's a criminal, somebody who's mentally ill, somebody who should be in jail instead of in the community. And we have to look at this glaring social inequity, including the health inequities. Most mental health crises that I've been involved in my 50 years did not, you were fine on Wednesday and you suddenly needed a 5150 on Thursday. It built over time. And because so many of our clients are isolated and alone and don't have contacts, they're living in desperation and they can't get the help they need until they reach a point of needing a 5150 involuntary response. And that's the best sign I know in the behavioral health system of how, by not developing a complex community system that is with individuals through the continued course of treatment, doesn't just drop them into an SRO in a community somewhere and waits for them to get symptoms and get to the point where they need to be hospitalized. That's what it would start to look like if we start looking at how this is a preventable acute system, much more than we allow it to be now.
So well, then let's go to the magic wand question. If the Black Lives Matter movement can lead to one systemic change, what would it be?
Well, I'll give an institutional neat answer. It would lead to more voices from those communities that present these inequities that result in either a disproportionate jail or disproportionate mental health to be in leadership positions. We need the voices of the people that are being served. If you look at the makeup of my agency at a leadership level, or you look at counties and you look at who the people are that are deciding the systems of care and setting them up, you will see that discrepancy flipped, where it's not 25% African American leadership. We need to have schools that teach community mental health that aren't only about the technology of mental illness, but are about the social determinants of people who end up being in that system. So if I could weigh I think one of the most exciting things for all of us, including the nonprofit sector, that does not blame us, including my agency, is it leads to a new commitment to recruit, develop, and have in positions of decision-making from the CEO position down to the counselor position who represent the clients that we're serving.
Thank you for joining us. Rising to Meet the Moment is a production of Behavioral Health Action, a coalition of more than 50 statewide organizations united to raise awareness about behavioral health issues in California. I'm Kevin Riggs. Thanks for joining us on Behavioral Health Champions.